with talking a lot. So I'm going to be talking about Prinzmetal angina, as Professor said. Okay, I'm going to first start with what is coronary artery. Coronary arteries are basically the arteries that supply oxygenated blood to the myocardium of the heart. And as Professor told us last time, that it has lots of small branches or collaterals, but they're very thin, so chances of developing coronary heart disease is more. Okay. What is Prinzmetal angina? It's also called vasospastic angina. As we know, the basal layer or the endothelial layer can go into spasm, and that's why it's like the name is vasospastic angina. It's different from stable angina and a little bit different from unstable, though it's a type of unstable angina. Okay. The main features is there will be no plaque present like in stable angina, where there is a stable plaque present. There will be sudden onset of pain. You won't even realize it. You might be just sleeping or resting and there will be sudden pain. Then, of course, the spasm of the coronary artery in particular. There will be angina or compression of the chest. And it's relieved by nitroglycerin. One of the main features of Prinzmetal angina is it's relieved by nitroglycerin. Unlike unstable angina, it's not really relieved. Unstable angina is not relieved by rest or medicines. The similarity between stable and Prinzmetal is that it's relieved by nitroglycerin. Okay, stable versus Prinzmetal angina. Number one, stable occurs during physical activity mostly, and Prinzmetal occurs mostly during rest. Of course, you're doing maximum rest activity during daytime, and Prinzmetal occurs from night to early morning. So when you have this particular period from night to early mornings, like dawn, is considered Prinzmetal angina because obviously maximum people are sleeping. Presence of stable plaque. Now, as we explained last class, stable plaque is when foam cells, cholesterol, like you have shoulders, it was explained, and here there's absence of stable plaque. Now, one is due to endothelial cell injury that results in the body developing, you'll have calcium, you'll have smooth muscle cells. It's the body's mechanism to help you treat the endothelial cell injury. But in this case, it is due to endothelial cell dysfunction. Now, our endothelial cell layer has particular cells. It's not just a layer, of course. Every layer is made of cells. Now, these cells go into particular dysfunction, so it causes Prinzmetal angina. Now, in stable angina, atherosclerosis is 100% present. But in Prinzmetal, this is the initial stage of atherosclerosis. Like you're going to slowly or gradually develop atherosclerosis. So Prinzmetal can convert into stable angina. Okay, now these are the exogenous causes of Prinzmetal angina. Now, as we all know, stress, number one factor. Medicines like vasoconstrictors. Now, why? Now, the first thing you can notice is our coronary artery spasm. Any spasm can be caused by vasoconstriction. It's basically constriction is spasm. So, if you take vasoconstrictor, it's obviously going to make it worse. Now, smoking, obviously, cold weather, and cocaine. So, cocaine, all these causes is similar to stable angina. And I have a short term for it, SMSCC. SMSC. Now, endogenous causes. The body also can develop. These are exogenous. Now we have endogenous or the bodily causes. Number one. Now, there are certain substances called basal dilating substances like endothelial derived hyperpolarizing factors or nitrous oxide, EDHP. Now, we all study this in physiology. Any membrane has polarization and depolarization, where we have sodium channels, potassium channels, membrane is for a impulse to pass or any message, we have to have polarization, hyperpolarization, depolarization. These factors, these factors are produced by endothelial cells and help the smooth muscle cells of the vessel to relax and help in dilation of the vessels naturally. These are naturally present in our body, it's not artificial. Now, as these vasodilating factors production decreases, hence lead to increase in the amount of opposing vasoconstricting factors. Our body is at equilibrium. It will produce equal amount of vasodilating and vasoconstricting. Now, if one goes down, obviously the other's level is naturally going to go up. So it leads to spasm. Like if you have natural vasoconstrictors, that will also help lead to spasm. Now, autonomic nervous system dysfunction and high tone of sympathetic nervous system. Now, we all know autonomic nervous system is composed of parasympathetic and sympathetic. Now, sympathetic nervous system is basically adrenaline, epinephrine, we have these. That leads to constriction, as you know, it will help in increasing the blood pressure. So if you have a high tone of sympathetic nervous system, it's bound to increase spasm. Now, alternate names of this is variant angina or angina inversa, because it's completely opposite to stable angina. Now, this is how we can see the artery spasm or rapid vasoconstriction, like suddenly, you don't expect it. Now, certain ECG red flags, this is not the only red flags because you can see ST elevation in this. This is not the only one, but in V3 and V4, you can see a slight ST elevation can help you determine that, okay, maybe this person has Prinzmetal angina. ST elevation.
During the attack, which is very typical for Prinzmetal angina and is not very typical for the usual angina. Yes, because if you happen to check ECG during the attack of a common angina, or angina, stable angina or unstable angina, most probably you will see ST depression, but not ST elevation. Yes, and that is why sometimes you can say, oh, I see it's like myocardial infarction, and sometimes they say this is acute coronary syndrome, the patient needs immediate hospitalization and we need to do a workup on this patient because most probably it's myocardial infarction. You see ST elevation is myocardial injury sign, yes, but not always, as you see, like here. Yes, it's not due to myocardial injury, but it's due to spasm of coronary arteries. It's not injury, it's not necrosis. But yes, it's ischemia, but it's not necrosis. Yes, but we see ST elevation, very strange thing. Yes, and that is why I told you that ECG is not very specific, not specific. Yes, if you see ST elevation in 95% or 90 maybe percent, it is infarction, it is death of the cells. Yes, but in 5 or 10% it's not infarction, it could be Prinzmetal angina, which is not death of the cells. It could be some other cause, for example pericarditis or something like that. Yes, but not myocardial infarction, not in all the cases. Sorry.
Okay, this is the localization of the angina. As you all know, it's constant in all the type of angina. It starts in the center of the chest, and like Sir said, it's not in the heart. It's basically at the center of the chest, and it radiates to. You can see all the radiating areas are marked. Basic central point is marked in red, and the pinkish part is where it can radiate. So if a patient complains of pain here, it could be any 3 types of angina. It's not exactly Prinzmetal, that's why written angina locations. Okay, treatment. Now, it's a combination therapy is required. Like all cases of angina, you need a combination of drugs. Now, calcium channel blockers, usually. Adrenergic blockers, because it's a high tone of sympathetic nervous system, and nitrates. You can learn it easily by CAN treatment. Calcium, adrenergic blockers, and nitrates. Simple. And the end. Thank you.
Thank you so much. Very good.